Assalamualaikum warahmatullahi wabarakatuh. My name is FARHANIS and together with me are Sabrina, Fatin, Wan Fatimah, Hidayah and Farah. In this video, we are going to present our case presentation titled Shwachman Diamond Syndrome. We hope everyone can gain new informative knowledge about this disease. For the introduction, Shwachman Diamond Syndrome or SDS is a rare autosomal recessive disorder with multiple and various manifestations. It is a multi-system disease that can commonly be characterized by exocrine pancreatic insufficiency, which can cause malabsorption of fats and other nutrients. Bone marrow dysfunction that results in low level of circulating blood cells and skeletal abnormalities such as short stature, abnormal bone development that affects the rib cage or bone. After cystic fibrosis, SDS is the second most common cause of exocrine pancreatic insufficiency in children. Children with SDS have a small but significant change of developing blood disorder such as myelodysplastic syndrome or leukemia. Nearly 5% of children with the condition will develop leukemia, with the risk rising up to 25% by adulthood. In addition, recurring infection including pneumonia, ears and skin infection are common. Many children with SDS also have growth problem and vitamin A, D, E and K deficiency. With modern treatment options and ongoing management, most children with SDS can lead normal life, although needs continued medication and regular monitoring through hospital visits. These are typically annual visits for children without any major problem or more frequently for those with complication. For the epidemiology, Shwachman Diamond Syndrome is a rare genetic disorder that may be apparent at birth, during early infancy or within the first few years of life. In rare cases, the diagnosis may be made during adolescence or adulthood. Reports indicate that the disorder affects males and females by a ratio of approximately 1.7 to 1. Reported incidence of 1 in 75,000 individuals and life expectancy can be until the third and fourth decades of life. According to National Organization for Rare Disorder in 2012, since 1964, over 100 cases have been recorded in the medical literature. Reported estimates concerning the disorder incidence have varied, ranging from 1 in every 20,000 births to 1 in every 200 births. The disorder are varies in severity from cases to cases, and since there is no exact test to make a diagnosis, it is very difficult to determine the true frequency of Shwachman Diamond Syndrome in general population. Next, proceed with the causes of Shwachman Diamond Syndrome. It is most likely inherited as an autosomal recessive trait. As you can see from the left pictures, recessive genetic disorder occurs when an individual inherits the same abnormal gene or the disease gene for the same trait from each parent. If an individual receives one normal gene and one gene for the disease, the person only will be carried for the disease but usually will not shows any symptoms. The risk for two carrier parents to both pass the defective gene and therefore have an affected children is 25% with each pregnancy. The risk to have a child who is a carrier like the parent is 50% with each pregnancy, whereas the chance for a child to receive normal gene from both parents and be genetically normal for that particular trait is 25%. SDS can also be caused by mutation in the SBDS gene on chromosome 7. It has been identified in about 90% of people with the characteristic features of Shwachman Diamond Syndrome. SBDS gene mutation can reduce the amount or impair the function of SBDS protein, which is widely expressed throughout the body in different organ systems. SBDS gene and SBDSP pseudogene are located in proximity on chromosome 7, and a possible conversion event between the two locus can result in mutation. SBDS normal function is actually to provide instruction for making a protein that is critical in building of ribosome. Ribosome are cellular structures that process the cell's genetic instruction to create protein. Therefore, when there is a shortage of functional SBDS, it can impairs the ribosome formation, which may reduce the production of other protein and can alter the developmental process.
Warahmatullahi wabarakatuh. My name is Fatimah binti Fatul, and today I will be presenting on the signs and symptoms of Shwachman Diamond syndrome, or also known as SDS. So the signs and symptoms in individuals with SDS, intestinal malabsorption will result in large, loose, foul-smelling stools that contain an excessive amount of fat, also known as steatorrhea, and other nutrients. Affected infants may fail to gain weight or may lose weight. Children with SDS may have larger or smaller appetites than normal and still be smaller than expected for their age, which may be due to malabsorption of certain necessary nutrients. As children with SDS grow older, the ability of the pancreas to produce digestive enzymes may improve slightly, leading to an improved nutrient absorption and relief of symptoms associated with malabsorption. However, even with improved absorption and acceptable weight gain, most affected children will be smaller than average for their age. Next is abnormal bone changes. Approximately half of individuals with SDS also have abnormal bone changes that may affect the rib cage and bones in the upper and lower limbs. For example, some affected individuals may have abnormal thickening of the ribs and their supporting connective tissue, also known as costochondral thickening, which will result in abnormally short and flat ribs. Rarely, abnormal narrowness of the rib cage may cause difficulties with breathing during infancy. However, such symptoms may improve later in childhood. In cases where bone changes in the limbs occur, the region where the long shaft of the bone, also known as diaphysis, meets its growing end, also known as the epiphysis, may develop improperly, known as metaphyseal dysostosis. In most cases, metaphyseal dysostosis have no harmful effects. However, improper ossification may cause growth delay in a particular bone, such as the femur and the tibia. For example, such changes may cause an abnormal reduction in the angle of the bone, potentially resulting in shortening of the legs, stiffness, and limping. For skeletal malformations, in rare cases, individuals with SDS may have additional skeletal malformations, such as fingers that are abnormally bent, also known as clinodactyly, and some affected infants may also have delays in tooth eruption, and their teeth may develop improperly, such as dental dysplasia. Next, another primary characteristic often associated with SDS is short stature. At birth, affected infants are usually of normal height and weight. However, shortly after birth, growth will slow, and by the first year of life, most children are below average for height and weight. Most children will continue to grow and gain weight at a normal rate but remain smaller than average. Some affected children may also have an abnormally large liver, known as hepatomegaly, which will present as jaundice, yellowing of the skin and eyes, nausea, and fatigue. Next, Shwachman syndrome is also characterized by abnormalities of the soft tissue within the bone, also called as bone marrow. Abnormal bone marrow will result in impaired production of blood cells, which include red blood cell (RBC), white blood cell (WBC), and platelet. In approximately half of individuals with SDS, there may be abnormally low levels of RBC, which will cause anemia. Because RBC contain hemoglobin, which functions to carry oxygen, low levels of RBC may result in an impaired ability to transport oxygen from the lungs to tissues throughout the body. Associated symptoms may include fatigue, abnormal paleness of the skin known as pallor, and other findings. In neutropenia associated with SDS, there will be an abnormally low number of neutrophils. As a result, they may be prone to repeated bacterial infections, including respiratory infections such as pneumonia, and infections of the middle ear, which is otitis media, and repeated bacterial infections of other areas of the body. They may also have additional abnormalities believed to result from an increased susceptibility to infections. These may include increased tooth decay, which can cause dental caries, mouth ulcers, and periodontal disease. Next, the bone marrow dysfunction associated with SDS shows a reduced number of circulating blood platelets, also known as thrombocytopenia, which play an important role in clotting the blood. Individuals with thrombocytopenia may bruise easily and, without appropriate precautions, they may be prone to abnormal bleeding. However, episodes of severe bleeding are rare. In some cases, it may lead to pancytopenia, which is the decreased levels of all cellular components of the blood, potentially in association with myelodysplastic syndrome, the MDS, which refers to bone marrow disorders characterized by abnormal stem cells and low levels of red blood cells, and platelets. MDS may precede the development of acute myeloid leukemia, a cancer in which cells that normally develop into certain white blood cells, the granulocytes, become malignant and abnormally proliferate. Only 1/3 of children with SDS eventually develop one of these conditions. Some individuals with SDS may also have additional physical abnormalities. For example, many may exhibit hyposalivation, though such symptoms do not appear to contribute to digestive abnormalities. In early childhood, some with the disorder may have various skin abnormalities, including rashes, skin that is scaly, dry, and rough, also known as the ichthyosiform lesions, and these skin abnormalities may decrease during later childhood. In some cases, children with SDS may experience a delay in reaching developmental milestones, such as sitting, crawling, walking, and learning to speak. However, by school age, the affected children usually reach their expected milestones. In rare cases, individuals with SDS may have cardiac abnormalities. For example, some have abnormal enlargement of the right side of the heart, also known as the right-sided hypertrophy. And in very extremely rare cases, individuals with SDS may also have nervous system abnormalities. These may include an impaired ability to perform certain voluntary movements known as apraxia, low muscle tone, hypotonia, and general weakness. And that will be all for signs and symptoms of SDS. This is my reference, and thank you for your time.
Hi, Assalamualaikum. My name is Sabrina ASRI. I'll continue to talk about how this syndrome can be inherited. Shwachman-Diamond syndrome, or SDS, can be inherited in two autosomal patterns. The first one is autosomal recessive pattern, and the second one is autosomal dominant pattern. For autosomal recessive pattern, there are three genes associated with this syndrome. The first one is SPDS, then AJC21 or EFLN1 gene. When two carriers of an autosomal recessive condition have children, there is a 25% chance to have a child with the condition. While in an autosomal dominant pattern, the gene associated is SRP54. In many cases of SDS, due to the SRP54 gene, condition occurs because of a new genetic alteration, de novo, we do not know the cause, and there is no history of this condition in the family. In autosomal dominant pattern, each child has a 50% chance of inheriting the alteration and the condition. Sometimes a person may have a gene alteration for an autosomal dominant condition and show no signs or symptoms of the condition. As we all know, most of our genes come in pairs, one from our mother and the other one is from our father. One of these cousins of genes is called SPDS. This gene should help the ribosome to get ready to work. Ribosomes consist of two parts, which are small subunit and large subunit. It doesn't work when two parts are separated. When the two parts join together to make protein, this is where SPDS protein is needed.
In over 90% of SPDS patients, that's where the problem is, due to a mutation in both copies of the SPDS gene. They don't produce enough SPDS protein, and as a result, they are not able to assemble enough ribosome, and therefore the cells cannot make as much of all the proteins they usually make. Scientists refer to this challenge as ribosomal stress. It can actually trigger cell death or senescence through the p53 mediated pathway. Ribosomes and SPDS are essential components of every cell in the body. If there is not enough, like in SDS patients, many organs or systems are affected, such as digestion, pancreas, bones, brain, blood, and immune system. Currently, scientists they came up with possible therapeutic targets in SDS. The strategies are to increase expression of SPDS and to increase amount of working ribosomes. Okay, if you want to know more about how this syndrome can be inherited, you can click this video, and it's actually a YouTube video. She explained more the details about how this syndrome can be inherited. About the chromosomes, ribosomes, and the possible therapeutics that I mentioned earlier. They actually have a series explained about the explanation about the science behind SDS. Okay, I think that's all. That's all for me. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is FARHANIS, and now I will proceed with the related disorders to Shwachman's diamond syndrome. Okay, the first one is cystic fibrosis. Cystic fibrosis is an inherited autosomal recessive trait disorder that affects many exocrine glands in our body, such as sweat glands, salivary glands, and those within the pancreas and respiratory system. In individuals with the disorder, glands within the lining of tubular air passage, which is bronchi in the lungs, produce unusually thick and sticky secretions of mucus, clogging and obstructing the air passage. So in addition, there is pancreatic insufficiency, which means that pancreas lacks the sufficient amount of digestive enzyme required to break down food and absorb fats and nutrients properly. The sweat and salivary glands may function abnormally as well. So for symptoms of cystic fibrosis, it may include failure to thrive, meconium ileus, which means that intestinal blockage, steatorrhea, which is loose, full, smelling stools that contain an excessive amount of fat, chronic cough, and increased susceptibility to repeated lung infection, and also abnormality salty sweat containing elevated levels of chloride and sodium. Okay, next is Persa-Mero-Pancreas syndrome. This is actually an extremely rare disorder in which red blood cells have an impaired ability to carry oxygen, which is known as sideroblastic anemia, and may cause by mutation due to changes in genetic material that affect the function of mitochondria. Additional characteristics may include abnormal accumulation of scar tissue, which means there is fibrosis within the pancreas. Malabsorption means that there is insufficient intestinal absorption, and the formation of abnormal cavities within the bone marrow, known as localization. Affected individuals may have a low birth weight. Failure to thrive means failure to grow at the expected rate during infancy, during the first year of life. Then wasting away, atrophy or absence of spleen, known as asplenia. And lastly, lactic acidosis means that there is abnormally high levels of lactic acid in the blood. Okay, the third one is Shwachman syndrome, which also known as genetic infantile agranulocytosis. So this is a rare inherited bone marrow disorder as an autosomal recessive condition, but autosomal dominant and X-linked inheritance have also been reported. So associated features include neutropenia, means that there is persistent, extremely low levels of circulating neutrophils. Then there is frequent bacterial infections and an increased susceptibility to developing myelodysplastic syndrome and acute myeloid leukemia. Okay, the next one is Johansen-Blizzard syndrome, JBS. This actually a rare genetic disorder that may be apparent at birth or early childhood. So, associated symptoms and findings may be vary greatly from case to case in this disorder. However, characteristic features include malabsorption of fats and other nutrients, failure to thrive during the first years of life, contributing to short stature, distinctive abnormalities of the skull and facial at the craniofacial region, hearing impairment due to inner ear abnormalities, which are also known as sensory neural hearing loss, intellectual disability, and hypothyroidism in one-third of the patients. Means that there is low activity of thyroid gland and underproduction of thyroid hormones. Okay, last but not least is metaphyseal control dysplasia, which is known as McCuskey type. This is actually a rare inherited disorder as an autosomal recessive trait. So, it is characterized by progressive short limb dwarfism due to abnormal development of cartilage at the ends of long bones, hair that is abnormally fine and sparse, impaired functioning of certain cells that play an important role in helping the body's immune system to fight infection, which is also known as cellular immunodeficiency. Additional features in this disorder may include malabsorption due to an impaired absorption of necessary nutrients during digestion, a chronic decrease in certain white blood cells, which also known as neutropenia and lymphopenia, anemia, which is low levels of red blood cells, and lastly, there is dental abnormalities, including delayed eruption of permanent teeth and malocclusion. Okay, then we proceed to investigations for Shwachman-Diamond syndrome. Okay, the first investigation that we can do is complete blood count, CBC. So this CBC is to assess neutropenia, anemia, and thrombocytopenia. CBC should also be obtained every 3 to 6 months or as clinically indicated. So for the first one, we want to assess neutropenia. cyclic or persistent neutropenia is observed in 88% to 100% of patients with Shwachman-Diamond syndrome, which is defined as an absolute neutrophil count (ANC) of less than 1,500 per millicentiliter in whites and less than 1,200 in blacks. It's categorized into three: mild neutropenia, moderate neutropenia, and also severe neutropenia. So for mild neutropenia, is defined as an ANC of 1,000 to 1,500 per millicentiliter. Moderate neutropenia is defined as an ANC of 500 to 1,000 millicentiliter. Then lastly is severe neutropenia is defined as an ANC of less than 500 per millicentiliter. So for assessment of anemia, anemia is present in more than 50% of patients with Shwachman-Diamond syndrome, secondary to iron deficiency and or bone marrow hypoplasia. The last one is to assess thrombocytopenia. Thrombocytopenia is present in more than 25% of patients with Shwachman-Diamond syndrome. The next investigation is liver function test. So this should be obtained at time of diagnosis and clinically indicated. So we have transaminases. There is alanine aminotransferase and aspartate aminotransferase may be elevated in individuals in Shwachman-Diamond syndrome. Then alkaline phosphatase may be within the reference range or slightly decreased. Findings on coagulation studies are normal and the serum bilirubin level is within the reference range. And hypoalbuminemia may be present secondary to malabsorption. The next investigation that we can do is 72-hour fecal fat measurement. So this is where there will be increase in fecal lipids and fatty acids is present in person with Shwachman-Diamond syndrome. So the fecal fat losses vary from 3% to 60%, and these losses decrease, which is after an individual with Shwachman-Diamond syndrome is aged above or in age 8 years, the fecal fat losses average 8% of intake. This decrease in fecal fat losses may be related to the patient's increasing pancreatic secretion of lipase coupled with the decreased dietary fat with age. So in this investigation, the absence of steatorrhea does not exclude the diagnosis of Shwachman-Diamond syndrome. The next one is secreting cholecystokinin quantitative stimulation test. In this test, there will be pancreatic insufficiency. Is evident by the absence or decrease of trypsin, lipase, colipase, and amylase activities in pancreatic secretion from less than 2% to approximately 10 to 14% of the reference range after quantitative stimulation test with intravenous secreting and cholecystokinin. Other tests that we can do is neutrophil function studies. A neutrophil migration defect may be documented. And then fetal hemoglobin. This is elevated in approximately 80% of patients with Shwachman-Diamond syndrome. Iron, folate, and vitamin B12 levels. So for the patient with Shwachman-Diamond syndrome, they may have associated iron, folate, or vitamin B12 deficiency secondary to malabsorption. So this test need to be obtained at time of diagnosis and as clinically indicated. Then we can proceed with immunoglobulin levels. So IgA, IgM, and also IgG levels may be low. And this test also need to be obtained at time of diagnosis and as clinically indicated. Then we can do growth hormone levels test. These are often decreased in person with Shwachman-Diamond syndrome. Then vitamin A, D, E, and K levels test. These vitamins may be low due to malabsorption. So we need to in this test we can obtain the vitamin A, D, E, and prothrombin time at time of diagnosis 1 month after initiation of pancreatic enzyme therapy, then every 6 to 12 months. Last but not least, the test that we can do is serum, calcium, and phosphorus. So these levels are within the reference range. These are my reference. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. I wish to Dr. Nick. My name is ATHIRAHUSNA binti NORDIN. I will continue to present the next SLO, which are to discuss the diagnosis and also treatment option for Shwachman-Diamond syndrome. Just for additional information, before we proceed to the diagnosis and also treatment option, Shwachman-Diamond syndrome can also be classified into several names, which are congenital lipomatosis of pancreas, metaphyseal chondrodysplasia Shwachman type, SDS, which is Shwachman-Diamond syndrome, Shwachman-Bodian syndrome, Shwachman-Bodian-Diamond syndrome, and also Shwachman-Diamond-Oski syndrome. All this kind of name is basically the same as Shwachman-Diamond syndrome. Okay, next we will proceed to the diagnosis. Initially, the clinical presentation of SDS is similar with cystic fibrosis, which both of them shows a sign of steatorrhea. Steatorrhea is defined as a presence of excess fat in the feces. So the stool may be bulky and it is difficult to flush. It also have pale appearance and it can also be false smelling. SDS is usually diagnosed at birth or during early childhood upon a thorough clinical evaluation, characteristic physical findings, and also specialized tests. In rare cases, the diagnosis may be made during adolescence or even adulthood. So, when steatorrhea is present without chronic respiratory abnormalities, a sweat test may be performed to help exclude a possible diagnosis of cystic fibrosis. This sweat test is done to confirm whether the patient is diagnosed with SDS or cystic fibrosis. So a sweat test measures the concentration of sodium and chloride excreted from the sweat glands. Although individuals with Shwachman syndrome and cystic fibrosis, they may have certain similar symptoms. For example, just what I have mentioned just now, steatorrhea. Individuals with Shwachman syndrome have normal concentration of electrolytes in their sweat. However, while those with cystic fibrosis, they have abnormal elevated concentration of sodium and also chloride. Next, several specialized imaging tests may be used to confirm the presence of specific abnormalities potentially associated with Shwachman syndrome. For example, pancreatic abnormalities such as fatty infiltration, which also known as pancreatic lipomatosis, may be demonstrated by computed tomography, CT scan, abdominal ultrasound, or even MRI. So during CT scan, a computer and X-rays are used to create a film showing cross-sectional image of an organ's tissue structure. In ultrasonography, reflected sound wave will create an image of the organs in question. And MRI will use a magnetic field and radio wave to create cross-sectional image of the organ. Various specialized tests of the pancreas may also be performed to help confirm pancreatic insufficiency. Such tests may include stool tests, blood tests, or analysis of secretion from the pancreas that are released into the duodenum. The duodenum is the first portion of the small intestine. Okay, next is bone marrow dysfunction. Bone marrow dysfunction may be confirmed and characterized by the removal and microscopic examination of fluid and also tissue sample such as bone marrow aspiration or biopsy. Various specialized analyses may be conducted on bone marrow fluid and tissue samples, including measure to identify myelodysplastic changes and chromosomal studies to detect the structural abnormalities of chromosome 7. For example, monosomy 7, monosomy 7q, and isochromosome 7q. Bone marrow dysfunction in those with Shwachman syndrome may manifest at different times by varying the combinations of neutropenia, thrombocytopenia, and anemia. Hematological problems due to bone marrow dysfunction may also be monitored by tests that measure the various types of blood cells in the circulation. Next, we go to skeletal abnormalities. Skeletal abnormalities are potentially occurring in association with Shwachman syndrome. For example, metaphyseal dysostosis and also ribcage abnormalities. Both of these syndrome, it may be identified by physical examination and also specialized X-ray study. And in some cases, additional diagnostic tests may also be conducted to detect the characteristics or to monitor certain abnormalities potentially associated with the disorder, which is SDS. Okay, next we go to the treatment option of Shwachman syndrome. The treatment of Shwachman syndrome is directed towards specific symptoms that are apparent in each individual. So the treatment may require the coordinated effort of a variety team of specialists who may need to systematically plan the child's treatment. So such specialists may include pediatrician, endocrinologist, physician who specialize in disorder of the endocrine gland, gastroenterologist, physician who diagnose and treat disorder of the digestive system, physician that is specialized in diagnose and treat skeletal abnormalities, orthopedist, physician specializing in blood disorders, hematologists, dentists, and even dietitians. Okay, the first standard therapies that can be given is vitamin supplement. Affected individual with pancreatic insufficiency may require pancreatic enzyme supplement with meals to promote proper absorption of fats and other necessary nutrients during digestion. So for example, fat-soluble vitamins A, D, E, and K may also be prescribed to prevent vitamin deficiencies that may result from malabsorption due to pancreatic insufficiency. A high protein or high calorie diet may also be prescribed in some cases to ensure that an affected individual's total nutritional requirements are met. In addition, physicians may also regularly monitor affected individuals for their hematological abnormalities associated with bone marrow dysfunction. As for example, physicians can do regular blood counts to ensure proper preventive measures and also early treatment. For example, affected individual with thrombocytopenia, dentists and other healthcare workers may recommend certain preventive measures before or even during dental work. For example, certain medication can be given to prevent or to lower the risk of abnormal and even uncontrolled bleeding. In some severe cases of neutropenia, anemia, and also thrombocytopenia, transfusions of specific blood components may be given to help reduce the associated symptoms. Okay, as mentioned by my friends earlier, some individuals with Shwachman syndrome, they are more prone to develop myelodysplastic syndrome and also acute myeloid leukemia. It is suspected that the incidence of leukemia may be increased in those patients with persistent blood abnormalities. So physician will take an action by closely monitor the affected individual's hematological status to ensure early detection and also to plan appropriate treatment. So physicians can conduct periodic cytogenetic evaluation to detect certain structural abnormalities of the chromosome 7 that may be potentially associated with myelodysplastic syndrome or acute myeloid leukemia. Periodic cytogenetic evaluation is the study of chromosome. So this will be done by testing a sample of cell for the presence of chromosomal abnormalities. Okay. Because neutropenia, it also can result in an increased susceptibility to bacterial infection. So, physician will closely monitor the affected individual, recommend preventive measure, and also given immediate antibiotic treatment. In severe cases of bacterial infection, hospitalization may be required. Okay. Okay, next, individual with Shwachman syndrome who experience recurrent infections and persistent low neutrophil count, they may be treated with granulocyte colony stimulating factor, GCSF. So GCSF is actually a growth factor. It stimulates the production of white blood cells. The decision to use this GCSF should be made after close consultation with the child's physician and also the medical team. Okay. Next is orthopedic measure. Orthopedic measure may also be taken to help treat or correct the skeletal abnormalities potentially associated with Shwachman syndrome. For example, abnormal bone changes causing a reduction in the angle of the thigh bone or the knee may be closely monitored to ensure appropriate and early orthodontic treatment. Okay. In severe cases, surgery, which is known as osteotomy, may be performed to help correct the angle from the head and neck of the thigh bone to its shaft, thereby will also reduce the stiffness and enabling the affected individuals to walk with less discomfort. Okay. Okay. Affected individual with neutropenia, they also may be prone to tooth decay and periodontal disease. So in such cases, dentists and other specialists may recommend special preventive steps or treatment for this condition. Early intervention can also be important in ensuring that children with Shwachman syndrome reach their potential. So special service that may be beneficial included speech therapy in cases of hearing impairment due to otitis media and other medical, social or even vocational services. Last but not least, genetic counselling may be benefit for affected individual. Other treatment option is symptomatic and supportive. By that, I end.
So this is my references.
I'm Hidayah. Next, I will continue with case report of Shwachman diamond syndrome that I get from this article. So the case summary is a 11-year, 7-month-old boy Indian presented with chronic diarrhea, which is crazy stool 5 to 10 times a day, and failure to thrive since birth. He also had frequent episodes of fever requiring antibiotics, and has recurrent oral ulcers, pruritic, papular skin rash, and dental caries. And there was no family history of pancreatic insufficiency or hematological disorders. Next, we move to examination. The first one is physical. This children has growth retardation. And the second is stool examination. It shows high fecal fat excretion. And the third one is palpation. The doctors see the palpate and they get a palpable soft liver without splenomegaly. And then the fourth one is extraoral. The doctor say hyperpigmented scar marks of skin lesions, and the final one is intraoral examination, which is dental caries. And then they did investigation. Number one is complete blood count, and the neutrophil count was 840 per Q millimeter, which is low neutrophil or neutropenia. And then normal hemoglobin, normal platelet, and the serum amylase, lipase, blood sugar also within the normal limits. And then second is blood test. They did liver function test, thyroid profile, and serum immunoglobulin, but all in normal. And then the third one is CT scan abnormal. And this diagram, it shows that the small white arrow here showing generalized fatty replacement of the pancreas. And then the fourth one is duodenal biopsy. And this duodenal biopsy also normal, but the bone marrow examination revealed mild marrow hypoplasia. So the diagnosis is Shwachman diamond syndrome. In this case, patient present with steatorrhea. Steatorrhea is the presence of excess fat in feces. And then the children has growth retardation due to normally children with this Shwachman diamond syndrome, it can affect child's pancreas and they may not get enough nutrients from food, thus it will cause growth retardation. And then neutropenia. Neutropenia is the most common in Shwachman diamond syndrome because neutrophil will fight against the bacteria. And then this affected individual usually are prone to get more repeated bacterial infections such as otitis media, pneumonia, and also they also may have dental caries, mouth ulcer, or periodontal disease, which is in this case the patient has dental caries. And then others infection is recurrent viral, bacterial, or fungal infection, skin infection, and septicemia. And then for the treatment and management, these children get pancreatic enzyme therapy, medium chain triglyceride, and also fat soluble vitamin supplements. So this pancreatic enzyme therapy will help to break food down into smaller nutrients that are easier to absorb. And then second one is hematological abnormalities. In this case is neutropenia. In Shwachman diamond syndrome, usually they may have stem cell transplantation and also bone marrow transplantation. That's all from us. Thank you.